funding sources, and promotes transparency and accountability in grant implementation for UPMB's impact and sustainability. So we look forward to hearing his talk about implementing high-impact social enterprise initiatives as a sustainable resource mobilization strategy. Welcome, Ronald.
Thank you. Good afternoon. I will be talking about implementing high social enterprise initiatives as a way of how we can be able to diversify our funding. I will begin by talking about Uganda Protestant Medical Bureau. We are a faith-based organization based in Uganda, and currently we have a network of about 330 member health facilities, and these are spread across the country. Our work is basically in maternal newborn child health, HIV, NCD, capacity building, and research. As you see on this map, those are the areas where we currently support. We've had a number of programs supported by the US government, but also supported in country by some other donors. Originally, as UPMB, we've been a typical not-for-profit entity. But as you know, things have emerged over time, and the needs of the organization keep on growing and growing, and therefore we need to sustain the services that we do offer. And therefore, as Uganda Protestant Medical Bureau, we established the Business Development Unit. And this was established in order to ensure that we are able to sustain, but also to scale up the programs that we do offer. All of us in this room, we are aware that funding continues to dwindle and continues to reduce. And you are aware that PEPFAR has been the largest program that has been offering services for HIV/AIDS. And we are all aware that the Global Fund to fight HIV/AIDS, tuberculosis, and malaria has also been one of the major programs that has consistently contributed to HIV response in Africa. Just recently this year, we are all aware that the US government halted most of the funding to most of the major organizations that we have in Uganda. And currently our government continues to fund as low as 7% of the national budget. What are the existing financing mechanisms that we have as Uganda Protestant Medical Bureau? We currently rely mostly on donations, on grants, and a pool of just a few internally generated funds. And as you know, most of the organizations in Africa, as UPMB, over 95% of our funding is external. And some of the funders that fund our work include CDC, Bread for the World, AstraZeneca, and most recently, USAID. As you are all aware, the funding has continuously dwindled, and therefore there is need to think outside the box on how we can be able to sustain the initiatives. And as UPMB, we have adopted a social entrepreneur outlook in the way that we are implementing our programs, such that we can be able to sustain them in a highly competitive environment, which is resource constrained. In our strategic plan, which we have just launched, that we run over the next 5 years, we are thinking of innovative financing strategies. And why are we doing this? We want to provide a level of stability, but also be able to generate revenue to deliver on our programs. And the social enterprise approach that we are taking on, we are looking at opening up regional optical centers of excellence, but also continue the community health insurance model. in the country. So this is the community-based health insurance model that we are implementing together with our member health facilities, where we have communities contribute small funds or small premiums to this, and it's on an annual basis over a period of 1 year, and they are able to access the basic medical services across the 330 member health facilities that we support. We are also working with the church in Uganda, the Church of Uganda, the Seventh-day Adventist, the Orthodox, the Pentecostal Church, to ensure that we can also enroll their members onto this community health insurance scheme, but also the clergy, such that they can be able to benefit from this. We are doing a lot of capacity building. We are doing mobilization. We are doing ongoing support, but we are also doing a lot of digitalization and monitoring, such that we are able to know how many people have enrolled, how many are using it, and how can we ensure that we make it better. As we continue to do this, and also the optical, these are the results that we have seen in terms of the social enterprise approach. In 2023-2022 financial year, we offered a range of optical services, as you can see there, including assessments, lens and frame provision, repairs, and we are able to see targets rising. As you look at this, we started with the Mengo Optical Center. We had a target of about 508 million Uganda shillings, and then later on we expanded to open up another optical center, and we raised over $100,000 US. For the case of community health insurance, we started with few members, about 94,000, and by the end of June 2023, we had over 100,000 members join our community health insurance scheme. So we've joined a number of health facilities, but also enrolled a number of dioceses across the country. And in terms of the community health insurance, we've raised over 1.9 billion Uganda shillings. And that, of course, means that at the end of the day, most of this money is going into the operations, the service provision, and we are able to raise about 10% as profit that comes into the organization to continue offering the services as a non-profit organization. This is to show you in terms of the graphical representation. We had a target of that, and the income, the green one, is the incomes that we raised in Uganda shillings. For the next optical center that we established, the target was 420, and we are able to raise about 95% of the target. And overall, we have seen an increase in the incomes that has come into the organization. We have challenges, just like organizations have. The dropout rates, because Uganda is an agricultural country, members tend to join when the season is up, and when the season is down, they tend to drop out. The low premium contributions, and on average, each member on an annual basis contributes about 20,000. That's about less than $10 per year, and that is able to offer the basic medical services. We've also seen low community health insurance uptake, the data challenges, because most of these member health facilities are in the rural areas, but we are trying to digitalize and to capacitate the health facilities such that they move away from the manual paperwork to the digital paperwork. In terms of the takeaways, as the funding continues to dwindle and to reduce, it is crucial that we think of social enterprise approaches that can be able to bring in money, but at the same time, we are able to continue providing the services that we do offer to the communities. As not-for-profit organizations developing countries, we need to integrate and link all our social development schemes or all our business initiatives to the HIV/AIDS, to the non-communicable diseases, to the maternal newborn child care services that we do offer. So this mix must be mixed to ensure that we continue to sustain the services. Thank you so much.
Thank you very much, Ronald, for staying within your time and such an interesting growth. Thank you for sharing that. Next, we're going to have our, our friend, Dr. Perry Jansen, an American family physician who served for approximately 16 years in Malawi with SIM and founded Partners in Hope, one of the largest regional HIV treatment providers, who will talk about Forward Together through African Mission Healthcare toward more impactful cross-cultural partnerships in healthcare mission.
Thank you. Glad to be here. This is one of my favorite groups because of the not just the ecumenical, but multiracial. It's great to hear, to get the perspective of people from all over the world. And it's sort of a reflection of what I'm going to be talking about today is really cross-cultural partnerships and some of the things that we found that work and don't work about cross-cultural partnerships. And I will tell you a little bit more about African Mission Healthcare and what we do. It is indeed a confusing time. And I think when you get to be a grandpa like me, rather than like getting busy and just doing things, you tend to sit back and think and try and figure out the big issues. And I want to just today, rather than spending a lot of time talking about what AMH is doing, I also want to just do a bit of reflection on the larger philosophical things about working cross-culturally and trying to build more sustainable, more enduring health systems. I think one of the key things, I was just talking to a gentleman who's trying to start a medical clinic in India. One of the key things is really recognizing that God is already at work. None of these things that have happened in our funding environment, in our local economies in the countries that we work in, has come as a surprise. And I think I learned very powerfully from Henry Blackaby and his study called Experiencing God, that God is always at work around you. And the best thing you can do is join God in what he's doing, rather than just being busy trying to figure out what you can do. And there's many verses really that support this philosophy to say, you know, you following God's path. And I also experienced this last verse that God is able to do exceedingly and above all that we can ask or even imagine. And in some ways, that sort of was my story going to Malawi in 2000, right in the midst of the AIDS epidemic. At that time, in 2000, probably 60% of the patients I saw were there with late-stage HIV. Many of them, I could do very little for them. I could maybe treat their opportunistic infection, put them on some vitamins and some Bactrim, and pray with them. And we had some home-based care programs that really helped them as they died with dignity, but they mostly died. And I got the privilege of being there from 2000 to 2016, where it just had a huge transformation in the availability of HIV treatment with antiretroviral therapies. And too long a story to tell you my involvement with the national program for that. But Malawi became really an example of how you can use a very low-cost, low cadre approach to delivering antiretroviral therapy and have huge impacts on mortality and survivability, and then the ongoing impact on the economy and a number of orphans. And so I was really just so privileged to be a part of that and to start an organization called Partners in Hope that actually I think is one of the larger HIV clinics, even in faith-based realm. Before January, we had about 1,500 employees, caring for about 220,000 people on HIV drugs. And so God, this wasn't because of me. This was God's thing that God did. And with the recent insecurity and uncertainties about the future, for my programs, for all of your programs, we have to remember this is God's thing. God's doing something. It wasn't a surprise. And really even start looking for the opportunities that come because of the faithful service that we've given over the years. And we'll talk a little bit more about that. My second broad lesson is to really embrace the diversity that comes from the Western partners, the things that we can bring, and us Western partners really recognizing the amazing knowledge base and relational connections that our local partners bring. You know, I think in the US right now, DEI is a 4-letter word, but diversity is powerful. One of the most powerful early experiences that I had that I think was really important for me was I started out working at a Bible college in their small clinic, and they had invited a professor who was he was a composer and an orchestra conductor, and he brought a whole bunch of brass instruments to train the African college students on how to play orchestral music. And they had a concert, and I think they chose, you know, Schumann or Beethoven or some Western piece, and they all started. And you know how in the beginning of orchestra they all play the A note and everyone tunes. You know, they play this out of tune and then everyone tunes. So he did that with them, tapped on, and they all played A, and it sounded so discordant. No one was in tune, but nobody tuned because they didn't really know how to tune. And then they started playing this piece, which I think, you know, sounded a bit like a junior high orchestra. And it was just really painful to get through. After that, then they had these guys. These aren't actual pictures. These are my AI because I couldn't find any good pictures. They had a group called the Kingdom Brothers, and these were some African students dressed in their colorful outfits with just a drum, singing their songs. And it was like I was in heaven. It was beautiful, beautiful. I read a book one time called Your Brain on Music, and it talked about how the music you listen to when you grow up is what you think of as something that is harmonious and beautiful. And so people, if you've grown up listening to rap music, nothing against, kind of something against rap, and someone plays Vivaldi, it's like, it sounds like noise. I grew up listening to Beethoven and Vivaldi. My mom was a concert violinist, and I can't stand rap because it's like discordant, but it's actually a neurobiological, your brain is used to this. This is harmonious. And it's a good reflection of what we do with culture, that as we go to a different culture, as I know Americans are probably the most guilty of that, we see all these things that it's like, oh, this is just not working. You need to do it the way that we do it. And often we end up doing what the orchestral, the composer did, and we're imposing something that's foreign and just does not fit. But recognizing not only, I think of these terms you've heard many times about cultural competence, where you learn a little bit about another culture and what things are offensive, how to approach them. I think even more important is to learn cultural humility and to recognize that the things that we see and the way that we see it is really shaped by our experiences and our cultures. And so to really appreciate the beauty of those two coming together and finding new ways to partner. Appreciate complexity. Mike Sarling was probably the first one that introduced me to the term complex adaptive systems, which really fit a lot of the places that we work, where things are very complicated and difficult to predict, and they're always changing. And so learning even some of the tools of how to work within and recognize maybe some common patterns and common solutions and common traps within complex systems. And as I work with our African health partners, one of the best things I think that we do for them is to map out their system. If they're trying to have a certain impact, say increasing their surgeries, just mapping out all the things that contribute to that, and then start thinking about where we have some leverage points that can change, dramatically change the output that they're looking for. Also looking for some of the places that are blocked, maybe the dependencies. You can't do this until you've done that and done that. And so just recognizing that the environments that we work in are highly complex. And if we think of linear, sometimes program management teaches you to think of, inputs and activities and outputs and outcomes. The world doesn't really work that way. It's still important to measure those things, but recognize that there are all kinds of unintended consequences that can happen, and there's some things that can be very high leverage. Fostering mutuality, and this is not just in planning, but in building trust to say, hey, we are doing this together. We're on a common path. I really love Paul Farmer's term, accompaniment, that we're on this same journey together, going to an agreed upon location, and you bring things and I bring things. It's not just mutual planning, but also mutual accountability, having them hold us accountable for what we're bringing to them. African Mission Healthcare is really, this is our mission statement. I don't have too much time, but we're really focused on strengthening health systems. Our primary customer is the Mission Hospital. And we always emphasize these 4 things that aren't in green as our distinctives, the thing that make us, that drive us, that these are the ways that we want to behave. We want to listen closely and engage in candid conversations with our partners. We're really hands-on, trying to help, not just send money, trying to focus on results, partnering long-term, and really emphasizing training. Engaging the church. I could talk a lot about this. We've talked before. If you're just doing everything yourself and not engaging the church, when things like loss of funding happen, the programs go away. And lastly, thinking long-term, not just doing things for today, but building things for the future to make them more enduring. I'm just going to, one of the main projects that I work on is helping to strengthen training hospitals, teaching hospitals in Africa, who are training the next generation of healthcare workers as well as healthcare leaders. And I'd love to talk to you about that if you have time, but I'm running out of time. And so I just wanted, and then we have, what we're trying to do then is also connect our partners to one another, to learn from one another, hospital administrators, surgeons, family doctors. And just one quick video.
Imagine an African country where every person can access quality, compassionate care. Mothers have safe delivery, children are healthy, and fathers can care for their family. This is the vision of African Mission Healthcare, and it is becoming a reality at our Mission Hospital partner. Today, we are treating patients by sponsoring surgery, shipping supplies, and supporting medical staff. AMH partners with Mission Hospital across the continent, providing resources and hands-on support. We are preparing for tomorrow by training our next generation of African healthcare workers, doctors, surgeons, anesthetists, nurses, and other healthcare professionals, developing African healthcare workers and leaders and helping them to become highly skilled, compassionate caregivers. For the future, we are building hospitals and health systems, strengthening African Mission Hospitals by supporting them with multi-year investment in infrastructure, equipment, housing, power, water, hospital governance, and other essential elements. Together, we are building stronger medical systems and healthier communities, treating patients today, training healthcare workers for tomorrow, and transforming hospitals for the future. Partner with us today and help make this vision a reality. Find out more at our website at www.africanmissionhealthcare.org.
Come see me after.
And for our final speaker in this session, I'd like to welcome Halik Adam, who is a program manager for Catholic Relief Services with 14 years experience in nutrition and, come on up, Holly. In nutrition and maternal and child health. And he's currently pursuing a PhD in health systems management. And he is going to share with us about strengthening health commodity supply chain management system in rural Ghana. Welcome, Holly.
All right. Thank you so much, and good afternoon, everyone. Yes, so I'm going to present on transforming health systems through innovative supply chain solutions, a case from Northern Ghana. Okay, so this is the outline of my presentation. Okay, so what is the challenge when it comes to supply chain of health commodities in Northern Ghana or in Ghana? We realize that the challenge is getting commodities and health supply to the rural parts of the countries, and then which we term the last mile health distribution. Yes, partners have come in, both bilateral, international, and even government agencies, to ensure that they are able to get health supplies and commodities to the last mile. But we do not have the true last mile. And so 40% of rural healthcare facilities report frequent stockouts of essential medicines, especially maternal and child healthcare medicines. Also, availability of supplies in support of safe childbirth remains a health system challenge, and we all recognize that we in CRS, we have been experimenting and using the 3 delays model, where we look at delay in taking decision about one's own health, delay in getting to the point of care, and then delay at the facility level, which is where the context within which health medicines and supply comes in. A lot of the time, people go to the healthcare facilities for care, but the essential medicines and supplies required to take care of them is not available, especially in rural Ghana. And so this is a major problem. Aside the non-availability of these medicines, we have a system where the system is able to supply medicines and medical logistics to the tertiary facilities, which are the teaching hospitals, the secondary healthcare facilities, regional hospitals, and also some of the mid-level healthcare facilities. But the challenge is at the primary level, which is the CHIPS, Community Health-Based Planning System, which is the lowest of our healthcare system in Ghana, and which also takes on about 60 to 70% of the population access health through the primary healthcare system. And so that is a major challenge that we are dealing with. And WHO recommends that safe childbirth by skilled birth attendants requires at least 28 essential birth practices, so of which 23 require one or more supplies. And so the challenge has been the inability of the system to get medicines and medical supplies to the last mile, who most often need these medicines and medical supply most. And so to be able to support in this regard, we undertook an assessment, and through the assessment, we're able to collaborate with our government partners to come out with a model that would support in improving the health commodity supply chain management system in rural Northern Ghana. And so first of all, we were able to identify supply gaps, and then also looked at route optimization. How do we ensure that we are able to get the right route to ensure that frequently we supply medicines to the healthcare facilities, that is the CHIPS compounds. And after this assessment, we came together and then co-created and came out with what we call modified tricycles for the supply of health commodities and medicines. This was particularly very important because in our assessment, we realized that most health staff, frontline health staff at the primary healthcare level would always use the excuse of going to get supplies at the districts and regional offices and vacate posts and abandon their core mandate of taking care of the sick. And so we realized that we need to put in a system that could ensure frequent replenishment of medicines and medical supply, and it shouldn't be the frontline healthcare worker doing that. Also, we also realized that at the district level, which is the district health administration for the supply of medicines and medical logistics to the primary healthcare facilities, they didn't have enough space to be able to accommodate medicines, or the space was not conducive enough in terms of its temperature and ability to keep medicines for long. And so we felt that this was also an important area we had to look at. And after that, we realized that we need to do some trainings for store managers, district store managers, on how to be able to put in a system to ensure that stockouts are identified early and that we are able to fill in before it completely depletes. And so those were the important issues that came up with the co-creation. And so to do this, we did do a deployment. We did come out with solutions on this, and then later we're able to deploy, advocate, and then monitor to get the results. I would go to the results later. And so this is it in terms of visuals. So the van to my extreme right is the health commodity van. We actually had to get a tricycle, modify it as a health commodity van to be able to cut commodities. And so part of what we did was to also train the district medical stores managers on how to pack based on the route, how to be able to arrange commodities in such a way that they conveniently are able to offload at points that need certain medicines and medical supplies. And so part of it, again, we had to train the health staff on how to properly use simple systems to be able to put in data and identify stockouts as early as possible. And the cross-docking station here shows the renovations that we undertook just to ensure that these health stores were conducive enough to take on these medicines. And so, yes, the health system as a change agent, we recognize that the health system can drive innovation to resolve service bottlenecks as it is, and then also strengthening the data systems is also very critical to ensure that we always have in stock medicines. And then also we were able to collaborate effectively with the Ghana Health Service to reposition our district medical administration as key leaders when it comes to the reform in terms of this medical stores optimization. So the context within which I'm speaking is the northern region of Ghana, which is made up of 5 regions now, with an approximately 97,700 square land area. It has one is the most poorest of our regions in Ghana, and multidimensional poverty rate of approximately 45.7%. So these are the key components of the innovation. I've already visualized that and mentioned the issue of getting commodity vans and tracking them with GPS system, and then refurbishing the cross-docking station using simple applications like WhatsApp to detect stock out, and then also staff training in supply chain management. And so the results, at the end of the day, we had 204 Ghana Health Service staff trained in 6 districts. 10 GPS tracked vehicles were deployed, 63 chips compounds served, and then 34 essential medical commodities were delivered with 32.14 metric tons transported. And so due to this intervention, we're able to reduce stock out rates by 60% across participating CHIPS compounds. We increased facility service delivery due to improved medicine availability, and we're able to enhance system responsiveness through real-time monitoring and alerts. Lessons learned. Local, we didn't do this in isolation, or we didn't reinvent any wheel. We used the local structures. And so local ownership and capacity building was very much crucial in this regard. And then also cross-sectoral collaboration, as well as using simple ICT tools. So the plan for scale up. Now, Ghana Health Services have taken this initiative up and they are running with it. We've also engaged the Ministry of Health to contribute into the supply chain master plan for the country. And then also this model aligns with SDG 3 and 9. So conclusion, call to actions. Health systems, when empowered, are agents of sustainable change. The rural health commodity supply chain model demonstrates how rural systems can drive equity and efficiency. And then investing in ICT and localized logistics to achieve universal health coverage in hard-to-reach areas is also very important. Thank you.
Thank you, Halik. It's always encouraging to hear things change. But I'd like to welcome our panelists up here. And while they're coming, just to have a seat for questions while they're coming, I forgot to introduce, I'm Kris Prenger. I'm a medical public health doctor. I worked in rural South Asia on partnerships in many ways between communities and the health system, between an NGO health system and the government. So all of these kind of touched on things that are close to my heart. We're just going to have a couple of questions, we'll kind of take a couple of questions and then we'll go ahead and allow the panelists. So if they're directed specifically to someone or just any general questions that you might have for people who are experienced, as you've heard, we'd like to welcome you to, I guess we don't have a mic, so we're a small group, so you can just shout from wherever you are. Any questions? Yeah, go ahead. And introduce yourself, please. And
thank you. Ali, thank you for that presentation. I'm just curious, were you working with government-owned health facilities or a mix of private as well?
Yes, thank you so much for the question. Mostly government-owned facilities, because at the chief's level, we do not have private hospitals or clinics operating. Yeah.
yeah, go ahead, Mike.
All right. I think it's to me. Yes. So, yes, very much so. I think that corruption also contributes to the gaps we are looking at. For instance, we realize, like I said, the current system is for the medical stores, the regional medical stores, to take in delivery of medicines and medical supplies and to give it out to the healthcare facilities who, based on the National Health Insurance Scheme, reimburse the regional medical stores based on use of these medicines. But most often than not, you realize that after even depletion of medical supplies, the amount that is paid back to the regional medical stores, usually some even as much as less than half of what was given to them. And so they blame the system. They are unable to even pay and get more supplies. And so to do this, the government of Ghana, in collaboration with partners, came out with a system they call the Gilmis system, which gives access to key people in the supply chain model to be able to tell real time what is available and what is being used, and then also to based on that to be able to get the the amount of money that has already been used in real time. Because corruption, once the money is lodged at an individual, with an individual for long, then you don't find it again. So they are able to frequently monitor and to ensure that payments are done on time, just to ensure that monies are not used by individuals. So yes, that is it. With the Gilmis system, it is helping to reduce the corruption. Yeah.
And I actually wanted to maybe give a couple of the other panelists an opportunity to respond just to that kind of general issue of, if we're talking about finances or just in general partnerships, how do we address that very basic injustice of corruption?
Thank you.
Yeah, you're on.
Currently in the country Uganda, also in line with supply chain, we've got a national supply chain digital system where the health facilities actually do order for whatever kind of medication that they need. And then we have two, the one that handles the public facilities, which is handled by government, Ministry of Health, and then the one which is handling the private sector. So we've also done the training, the capacity building, such that these health facilities are able to monitor, order, and track whatever kind of supplies, such that it can reach the facilities and do the intended objective.
Amen.
I think in addition to, I mean, every country has its corruption, but in addition to corruption is, I think that feeds into continued poor performance. It's just as low expectations to say, well, this has never worked before, it's not going to work now, or they don't keep good track of things. And somehow raising the bar and creating that expectations that things, and that's why I think model programs like this can show this can be done even here. Yeah.
Yes, go ahead.
Mission healthcare, yeah.
My question is directed to Uganda. About the community health insurance scheme. We know almost every other country signed the government doesn't have coverage. Government for cases where the Chinese have a scheme like this and it's competing with the coverage program. How that can manage that of Uganda, where the community health insurance that's what they call it. But I know when program to by the state. So that one is like meant to free cost also by the state, they have a program also planted. That's the first area of concern. The second area of concern is I see two people are companies as part of the sponsors in Egypt. the organization. But this as the AstraZeneca. My concern is knowing what big pharma are, and I said, don't they have an influence on the type of drugs that you use in your facility as the branded medication that influence the cost of treatment?
Go ahead, Ronald. Yeah. And if you could just kind of restate what you're responding to when you say it for the Zoom.
Okay, so thanks for your question, and I hope that I got your question well. As you are aware, currently in Uganda, we are proposing, the government is currently proposing the National Health Insurance Scheme, but also at the same time, we are running the Community Health Insurance Scheme. So what we are currently doing, we are a member of the Ministry of Health Policy Advisory Committee. So we are sitting together with government to see that the lessons that have been learned, the good things that have been done under community health insurance can actually be adapted into the National Health Insurance Scheme. Now, we are working with the health facilities. And when you look at the membership coverage, we normally allow members from a specific district in the country or a specific region, groups of people to come together, pool their resources, and be able to access the services. So for us not to have a lot of duplication, but also to ensure that there is a policy that will be able to manage this, we are working hand in hand with government to ensure that it can be adopted into the National Health Insurance Scheme.
Right, we maybe have time for one more question, just so everybody know, the panelists know. I'm just going to ask for a very quick, you had your lessons learned, but I'm just going to ask for a little one bullet point, one key takeaway after this next question, and then we'll finish with prayer. So we need about 5 minutes at the end. Yeah, go ahead, Laura. So Halik, if you can respond to that question about quality of the actual medications that make
Yes.
it to facilities.
Yes, so yes, with the first of all, we are working through the Ghana Health Services, and the partners we work with are government officials who have been trained in the management and supply chain management of medicines and medical. So most of these district medical stores managers are pharmacists and also people within the supply chain fraternity. And also, as part of what we do, that is what we do an assessment to look at the current standards. And that is what we call the cross-docking station to see if it meets international standards and it also meets the standard of keeping medicines and supplies, including cold chain, that would still be potent for use. And so after this assessment is done, where there are gaps, we support the system to be able to improve. So sometimes we go as far as fixing air conditionings where they are not present. We also provide water systems. We provide shelves to be able to properly store medicine, and then the cold chain system to ensure that there are actually standards by the Ghana Standard Authority and then government on how a storage facility, medicine storage facility should look like. So we make sure that it meets standards before we are able to carry any medicines there. So yes, an assessment is done based on the existing standards and improvement made before we are able to provide medicines and supplies. Yeah, thank you.
Got a little bit more time. Anyone else have a question? Yeah.
All right. So this last part, I didn't get it. Yes. Okay.
Just a very, very brief response. We're running out of time.
All right. So yes. So we use multiple factors, not just one, to be able to reduce the stock out. I mentioned about expanding the medical stores to be able to accommodate more medicines and supplies for the districts. For instance, if you have a small medical store which can only take like stock for just 1 month, when there are stockouts and then you have to request for more, then it may take additional month or two. But once you have an expanded store that can take stock for up to 3 to 4 months, then you are supplied to be able to also supply to the hospitals within your jurisdiction or healthcare facilities. The other thing about it is getting the health commodity van, which support in ensuring that we are able to get the medicines and supplies in real time to the healthcare facilities that make requests. And this request is also based on payment. So with data available, we are able to know when a particular facility requires supplies or when a facility is running out, and in real time, we are able to get them their supplies. So
And then-
those are the, yeah.
Then we can track the truck.
Yes.
It was-
We track the truck to ensure that they are actually used for the purpose for which they were purchased. Yeah, thank you.
Thank you. Maybe I'll ask Perry, since you're in the middle, but just the 1 minute, what is your key takeaway?
I think, with the rapid changes that are happening in foreign assistance and changes that are happening in healthcare missions, I think really trying to explore more egalitarian ways of partnering with our local partners, that we're not moving towards, like, I don't really like the word decolonizations, because it's like, we don't want any white people here, but to really explore. And I think the great metaphor is the body of Christ. What do we all bring? How do we work better together? Yeah.
Thank you, Perry. Ronald?
As the funding continues to dwindle and reduce, it's pertinent that we think about innovative mechanisms that can be able to bring in resources, and we continue with the vision and mission of our different organizations that we support. Thank you.
Thank you. And I'll give you one more chance, Ali.
Okay, so I think this is the time for us to collaborate more, and then also to try as much as possible to use indigenous structures, to be innovative in using indigenous structures to be able to deliver results. Yes, thank you.
Thank you very much for your just hopefulness. So what I'm struck by just listening to these is what I think a Christian superpower in these spaces is our hope. We persevere. So there was, what struck me on one slide was we're working towards sustainable change, but actually the change, we need to be good at how do we address change. We remain hopeful in it, we innovate, but we remain persevering in courage that health and wholeness is possible, and our restlessness as we work toward that. Innovation, if you're entrepreneurs, is about working towards, what do I want to say? Your stakeholder, cash money delivered. Here we are pursuing the delivery of health and wholeness, which glorifies our Father. So thank you to all the panel, and I'm just going to wrap up with a short prayer. Lord, we just do give you glory in how the pursuit of what is just and what is right for both an individual and also a system, that we need your Holy Spirit to enliven us and to give us these bold new ideas that sometimes reframe the ideas of the world, that incentives matter, money matters, but relationships matter and integrity matters. Thank you for that highlight in this conversation, that at the end of the day, we're fighting injustice, we're fighting death, but we are fighting for you and in your power. So thank you for that. In Jesus' name, amen.
Great picture together.
Oh, gosh.